Hi, good afternoon. Thank you for this opportunity to share with you our experience with cryptococcal infection in kidney transplant recipients. We have no disclosures to make. A few words about the background. Cryptococcal is the third most common fungal infection in solid organ transplant recipients, ranking only third after invasive candida infections and Aspergillus. The reported incidence varies according to the series from 0.5 to 5%, and it presents typically as a late infection with median time of 16 to 21 months after the transplant. Treatment recommendations are extrapolated from other populations, mainly HIV, because there are no randomized control trials in this population. The guidelines suggest that the use of induction therapy with 5-fluorocytosine and liposomal amphotericin B is the most effective treatment, but we don't have in Argentina 5-fluorocytosine, so we thought that it's interesting to present our results without this ideal treatment. This is a retrospective analysis spanning over the decade, and we're going to present data on demography, immunosuppression, clinical presentation, treatment, and outcome. In that period, we performed a little over 1,400 kidney transplants, and we observed 12 cryptococcal. All of them were Cryptococcus neoformans group infections. The incidence is 0.85%. 9 patients were female, 3 male. The donors are in the pie chart, and median age was 44 years almost, with a wide range from 20 to 72. 10 of our patients with cryptococcal infection received induction with thymoglobulin. Maintenance immunosuppression is breakdown in the pie chart. Most of them were on tacrolimus, mycophenolic acid, and prednisone. And although 4 patients suffered rejection episodes, these episodes were quite separated in time from the actual onset of the cryptococcal infection. And that onset occurred a median of 27 months after the transplant, and we were able to obtain CD4 count in 5 patients. And this low CD4 count does not seem to be related to an increase in immunosuppression. They were under stable maintenance regimen, so it's surprising. Half of the patients have meningeal forms. One of them had a post-mortem diagnosis, and the others have disseminated and pulmonary and pleural forms. Our treatment was, as I said, liposomal amphotericin B, 5 milligrams kilo, for at least 2 weeks. And we do normally spinal tap at 2 weeks and only stopped amphotericin B when cultures of CSF are negative. And after that, we followed fluconazole. Immunosuppression was cautiously minimized to avoid the development of iris until infection was controlled, and there we went back to the maintenance regimen. Of the 10 patients that are still on consolidation, 8 completed treatment, a median range of almost a year, and 2 are still under treatment. And to say that in a nutshell, well, of the 11 patients, 1 died of disseminated disease. This was the only early presentation. All the others were quite late. And 10 patients are with a cure or with controlled infection. And among these patients, 2 suffered graft losses that were unrelated to the infection, and the remaining 2 are still completing maintenance. And of the patients that were cured, we followed up them. You have to add 6 months to this period, and none of them received secondary prophylaxis, and we observed no relapses. So the conclusions are that at least in some patients, a low CD4 count may be observed concomitant with cryptococcal infection, that our treatment without 5-fluorocytosine, with or without fluconazole, followed by fluconazole consolidation and combined with an wise management of the immunosuppression was quite successful in our experience in the management of this infection. And no relapses were observed in patients with treatment completed and no secondary prophylaxis. Thank you.
Questions are open. Please.
From the Gregorio Marañón Hospital in Madrid. I'm an immunologist and I am interested in infections after transplantation. The data regarding the CD4 T cells that you have are very interesting. Have you compared the amount of cells that were below 100, that is very low, in patients who didn't present cryptococcal or any other opportunistic infections at those time, more or less?
No, we don't have that, and that's very interesting. I found difficult to get the data of how is the count, the normal count of a late transplant patient. And I found that there are about 800, 1,000 CD4 in the few publications that I was able to find. But this is interesting to compare. I wonder whether the cryptococcal infection itself may cause a go down of the CD4 count as occurred in severe cases of tuberculosis. We observed patients with severe tuberculosis, CD4 counts that went down, other infection, opportunistic like pneumocystosis, and recovery when the tuberculosis was treated. And we wonder whether this could be the case.
May I ask, with regards to that question, the percentage of CD4 cells is as relevant as the absolute number. A patient can be leukopenic because of the medications, and the CD4 cell count will be low. What was the percentage of CD4 cells compared to CD8 and other lymphocytes? Was that altered in these patients?
Yeah, that's important. I don't have the exact percentage, but we are planning to write it, and we'll get that data.
Thank you very much, Doctor.
Thank you.